This is a 60-year-old lady who has dense nuclear cataract along with a posterior cataract. She has a grade 4 nucleus, but beneath it she also has a PPC. Although in this eye it's not very clearly visible, the other eye, which has got a lesser density of nuclear cataract, shows the classical onion peel appearance of a posterior cataract. So I have planned a manual small incision cataract surgery in this posterior cataract, just in view of the very dense cataract which the patient is having. So let's see how things turn out. So as we all know that the incidence of PC tear is significantly higher in eyes with posterior cataracts. Although a phacoemulsification is my usual procedure of choice in these polar cataracts. Now, in this case, looking at the density of the nucleus, I just thought that maybe a manual MSICS would be a much more safer option. So I'm going to try that and let's see how things turn out. The surgery is being done under posterior subtenous anesthesia. I'm injecting 1.5 ml of lignocaine in the inferior medial quadrant. I'm also creating a bleb using the same lignocaine near my incision site. The conjunctival flap is raised. 6.5 mm sclerocorneal tunnel is done. Two side ports are made. I'm going to use the bimanual INA, so there's a reason I'm using these two small side ports. The capsule is stained. OVD is placed into the eye. I have used a dispersive OVD to begin with. The internal incision is done, and now is the time to perform the rhexis. Now consciously, because I'm dealing with a slightly denser nucleus, I'm going to use the same standard oval rhexis which I usually use for my phacoemulsification, and I want it to be bigger on either of the poles which is parallel to the main incision. So as we don't do hydrodissection these posterior cataracts, I'm resorting to a manual dissection, which is just using a blunt spatula or a hydrodissection cannula just to manually separate the cortical attachments to the anterior capsule up to the equator. This is repeated on either side. This is a technique which I learned from Dr. Chakrabarti many years back. Time to mobilize the nucleus out of the capsular bag into the antechamber. I'm using HPMC to reform the chamber using two Sinskey hooks. The nucleus is gently maneuvered out of the bag. Now, since the rhexis was adequate sized, the nucleus mobilization into the antechamber was quite effortless. Now, before extracting the nucleus out again, I'm refilling the chamber both underneath and above the nucleus with HPMC to ensure that the chamber is maintained throughout. Using the phaco sandwich technique, the nucleus is grasped between the underlying vectis and the overlying dialer and then gently extracted out. As the nucleus is being extracted out, the posterior capsule tear is just staring at me. And as the nucleus comes out, there is also a momentary shallowing of the antechamber. Well, in spite of all the necessary precautions, the posterior capsule is wide open now. So at this point, I don't think the anterior hyaloid is ruptured yet, so let's find out. I'm trying to refill the chamber with OVD, that's HPMC, injecting from either side port, trying to be consciously away from the central area, trying to place the OVD in the peripheral part of the antechamber. So at this point, I'm very confident that the anterior hyaloid is still intact. I don't see unusual change in the configuration of the posterior capsule tear, which could suggest a ruptured hyaloid and a vitreous prolapse. So looking at the margins of the posterior capsule tear, which are quite regular, I'm still confident that the anterior hyaloid is still intact. I want to remove the cortex now. So I've decided to go in with the bimanual INA itself. So one prerequisite which I always ensure in such situations where the PC is open but the anterior hyaloid is still intact is to decrease the bottle height to significant levels. At this point I've kept it at around 50 centimeters down from 100 centimeters and then gently going in with my aspiration cannula to tease out each of these cortical fibers. Now because the anterior hyaloid was quite intact, I was pretty much relieved and there was a momentary lapse of concentration, and instead of putting in OVD before switching hands, I abruptly take out the hand and there is a shallowing of the chamber, and it was my lucky day. In spite of this momentary shallowing, the anterior hyaloid continues to be intact and the cortex from the other end is now being aspirated out. As the last bit of cortex is being removed, this time I am very mindful of not coming out with the irrigation handpiece. Instead, as is customary, I'm going into the antechamber with my OVD and gently inflating it as the irrigation handpiece is withdrawn, ensuring that there is no chamber fluctuation. As the OVD is being injected, let me pause for a minute here and just show you the edges of the posterior capsular tear. When the posterior capsule is split and the edges are regular, not splayed or not widened in one quadrant or the other, this is a clear indication that the anterior hyaloid is still intact and there is no vitreous disturbance. So just looking at the edges of the posterior capsular tear can give you some idea of whether the vitreous is prolapsed or not. The planned multi-piece lens is to be placed in the sulcus. To facilitate that, I'm going to use the cohesive OVD, which is going to form and maintain the space between the iris and the anterior capsule, that's the ciliary sulcus. So when the lens goes in through the large scleral tunnel, we don't have the shallowing of the chamber, and I can easily navigate the haptic of the lens under the iris and above the anterior capsule. The lens is gently dialed so that the haptics are 180 degrees from the long axis of the oval rhexis. This facilitates us to achieve an optic capture through the smaller diameter in the axis parallel to that of the haptics. Now, before achieving optic capture, it's mandatory for us to remove the OVD in front of the lens and if possible from behind as well. But in this situation, it's an open posterior capsule. It's debatable whether you would want to go ahead and do the OVD extraction. You can obviously leave it as well, but I prefer to go in and remove all the OVD as well. This is possible to do without rupturing the anterior hyaloid. The only secret is to decrease the bottle height. Gentle irrigation ensures that whatever OVD is sticking out to the back surface of the lens and below the lens is gently irrigated out, and this is all possible without rupturing the anterior hyaloid. Then the OVD which is in front of the lens is gently aspirated out. Now with the irrigation handpiece in my left hand, the optic of the lens is gently nudged posteriorly so that the optic gets behind the rhexis margin and we have some sort of an optic capture in. Diluted triamcinolone acetate is used to confirm the absence of vitreous. Diluted pilocarpine is used to constrict the pupil. The conjunctiva is closed. That's it, the case is done. So these are the first day post-op pictures, and the patient continues to do well over subsequent follow-ups. Let me take you through some key moments in the surgery. Now, I'm asking myself, could I have prevented the posterior capsule rupture in this eye? Was it pre-existing? I'm not sure whether it was pre-existing because the anti-segment OCT was not possible in this case for logistical reasons as it was being done in a peripheral center. Nevertheless, the moment the nucleus was being extracted, the underlying posterior capsular tear was very much evident. Now, if I had a second chance in this patient, the one thing which I would have done differently is, as the nucleus was maneuvered out of the bag, I would have used a dispersive OVD like viscoat or viscoat-like substance, which would have maintained the chamber and prevented the microfluctuation of the chamber, which could probably have resulted in the rupture of the anterior capsule, especially during nucleus mobilization and also during extraction of the lens. So I would have made that one modification, otherwise it is fine. The second thing to learn from this case is the anterior rupture and posterior capsular tear are two independent entities, and if we are careful and sensible, then in some scenarios the rupture of the anterior hyaloid and subsequent vitreous prolapse can be minimized. Thank you for watching and hope you found this helpful.